Let's dive straight into this clinical sprint explainer covering regional anesthesia and pain management. We've got a lot of high-yield ground to cover, so let's get right to it.
All right, question 39. Which of the following lies posterior to the axillary artery that can be damaged during administration of an axillary nerve block? Could it be the ulnar nerve, median nerve, radial, musculocutaneous, or the brachial plexus?
The correct answer is C, the radial nerve. Think about the spatial anatomy of that tight neurovascular sheath. The radial nerve sits directly behind the axillary artery, which makes it incredibly vulnerable to needle trauma if you're using a posterior approach. And here's a quick clinical pearl. Notice how the musculocutaneous nerve actually branches off early to travel outside this main sheath, right into the coracobrachialis muscle. That perfectly illustrates why you need a totally separate targeted injection if you want to completely block the forearm.
Moving right along to question 40. Which of the following nerves is most commonly damaged in an axillary nerve block? Are we looking at the ulnar nerve, median nerve, radial nerve, musculocutaneous nerve, or the brachial plexus? It's A, the ulnar nerve. This is a big one to remember. Out of all the terminal nerves in that bundle, the ulnar nerve carries a massive 28% incidence of iatrogenic needle trauma during these blocks. Just keep in mind, the axillary block is fantastic for surgeries of the hand, wrist, and elbow because it covers the ulnar, median, and radial distributions. But it frequently misses the musculocutaneous and intercostobrachial nerves, so you'll always need to account for those separately depending on where your surgeon is working.
Question 41. All are good means of preventing heat loss in a hypothermic patient except. Is it switching off the AC, using warm fluids for resuscitation, blankets, a warm fan, or just avoiding unnecessary exposure of the patient?
Correct answer here is D, use of a warm fan. Let's really dive into this thermal dynamic because it trips people up. Convective forced air heating has to be used very carefully. If your patient is wet from blood, surgical prep, or sweat, blowing air across their skin aggressively increases evaporative heat loss. It actually drops their core temperature paradoxically. Since anesthesia blunts central hypothalamic thermoregulation, we have to rely on passive insulation, like trapping metabolic heat with dry blankets and covering the head, combined with active caloric transfer, like infusing IV fluids warm to about 37 to 42 degrees Celsius.
Question 42. Phantom limb pain will least respond to which of the following class of drugs? Antidepressants, monoaminergic drugs, non-steroidal anti-inflammatory drugs, clonidine, or none of the above?
The answer is C, non-steroidal anti-inflammatory drugs. NSAIDs just don't cut it here. Phantom limb pain is entirely neuropathic. It's driven by structural neural remodeling, ectopic firing, and central sensitization, right in the spinal cord. Absolutely not by peripheral inflammation. Since NSAIDs target peripheral cyclooxygenase enzymes, they completely fail against these intrinsic neural pathway injuries. Instead, your mainstay pharmacotherapies are going to be anticonvulsants like gabapentin to dial down excitatory neurotransmitters, and antidepressants like duloxetine to boost descending inhibitory pathways.
Let's pivot from pain pathways to pain relief. Question 43. Which of the following substances are increased by nerve stimulation procedures done for pain relief? Substance P, bradykinin, endorphins, histamine, or endothelin?
The correct answer is C, endorphins. Let's walk through the gate control theory step by step. First, you stimulate those large, non-nociceptive A-beta fibers. Step 2, this activation wakes up the inhibitory interneurons in the dorsal horn's substantia gelatinosa. Step 3 is the payoff. It triggers the central nervous system to release endogenous opioids. We're talking endorphins, enkephalins, and dynorphins. Finally, step 4, these peptides bind to their receptors and literally close the gate, completely blocking pain signals coming from the unmyelinated C fibers.
Question 44. A patient develops hypotension following spinal anesthesia. There is no evidence of ongoing fluid or blood loss. Which of the following is the best management step to counteract this hypotension? Would you use intravenous dopamine, dobutamine, a fluid bolus, sympathomimetics like phenylephrine and ephedrine, or none of the above?
The answer is D, sympathomimetics. So when local anesthetics hit the subarachnoid space, they block sympathetic preganglionic fibers from T5 to L1. What you have here is a chemical sympathectomy. It causes massive venodilation and arterial vasodilation, which leads to venous pooling and a suddenly dropped cardiac preload.
If there's no fluid loss, you have to restore systemic vascular tone using alpha-1 agonists like phenylephrine or mixed agents like ephedrine. And don't forget the high spinal bradycardia rule. If your block creeps above the T4 dermatome, it knocks out the cardiac accelerator fibers. That causes profound hypotension and bradycardia that demands immediate atropine or epinephrine.
Really quickly, question 45 asks where drug is instilled during spinal anesthesia. Correct answer, B, the subarachnoid space. Remember your anatomy. In adults, the spinal cord ends at L1, but the subarachnoid space safely extends down to S2. To get your needle there, you're sequentially piercing the skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space, dura mater, and finally crossing the arachnoid mater.
Question 46. Which of the following is the best method for pain relief in a patient with critical limb ischemia, having a skin ulcer and rest pain? Are we doing oral tapentadol, oral paracetamol, oral pregabalin, a regional block, or a lumbar sympathectomy? Correct answer is E, lumbar sympathectomy. When a patient has severe, unremitting rest pain and standard vascular reconstruction just isn't an option, interrupting the sympathetic chain at the L2 to L4 levels is an absolute game changer. Delivering a neurolytic agent like phenol around this chain completely eliminates sympathetic vasoconstrictor tone. This powerfully dilates collateral blood vessels to improve microvascular perfusion, and as a bonus, it severs the visceral pain fibers traveling right alongside those nerves.
Question 47. Which of the following will assess the adequacy of a lumbar sympathectomy? Absence of sweating, absent pain on rest, absent vibration sense, absent paresthesia, or none of the above?
Okay, we need to make a really critical distinction here. While the provided answer key states absent pain on rest, you have to remember that is merely a subjective clinical outcome. If you want to objectively confirm a successful sympathetic block immediately at the bedside, you need to look for pseudomotor signs. The true physiological indicators are anhidrosis, which is just the absence of sweating, and a 1 to 3 degrees Celsius temperature bump in the ipsilateral foot because of that hyperemic vasodilation. And remember, somatic functions like vibration sense and deep tendon reflexes, those stay completely intact.
Question 48 asks us to identify the incorrect statement regarding NSAIDs. Is it related to gastric erosions, a decrease in renal function, a decrease in platelet function, steroid synthesis, or decreasing the inflammatory response? The correct answer is D, steroid synthesis. NSAIDs block cyclooxygenase, or COX enzymes. They literally have absolutely nothing to do with steroid synthesis. When you look at their actual adverse effects, it's all incredibly logical. Gastric erosions occur because blocking COX-1 removes your cytoprotective prostaglandins. Renal impairment happens because you lose the specific prostaglandins that keep the renal afferent arterioles dilated. And platelet dysfunction, that's caused directly by the disruption of thromboxane A2 synthesis. Question 49. Which of the following is an unnecessary intervention for monitoring and care during elective repair of a bilateral inguinal hernia? Blood pressure measurement, radial pulse measurement, ECG monitoring, central venous line placement, or oxygen saturation measurement? Correct answer is D, central venous line placement. Let's be real, a bilateral inguinal hernia repair is a superficial soft tissue surgery. Dropping in a CVP line carries major invasive risks like a pneumothorax or vascular injury and is strictly reserved for major intrathoracic operations, massive expected blood loss, or if you need continuous vasopressor infusions. For a routine hernia, standard baseline monitoring is all you need: non-invasive blood pressure, continuous ECG, pulse oximetry, and capnography. Question 50. A 74-year-old woman presents with a small bowel obstruction. Which of the following inhalational anesthetics should absolutely be avoided because of the risk of accumulation in air-filled cavities during general anesthesia? Diethyl ether, nitrous oxide, halothane, methoxyflurane, or trichloroethylene? The correct answer is B, nitrous oxide. Here's the physics behind it. Nitrous oxide is roughly 34 times more soluble in blood than nitrogen. When a patient has a mechanical bowel obstruction, that trapped intestinal gas is mostly nitrogen. So when you administer N2O, it diffuses into these gas-filled cavities way faster than the nitrogen can be absorbed back out into the bloodstream. This progressively blows up the bowel. Because of this, mechanical intestinal obstruction, acute pneumothorax, decompression sickness, and intraocular gas bubbles are all absolute contraindications for nitrous oxide. Wrapping up with question 51, which asks for the mechanism of action of local anesthetics. Correct answer is D, blocking voltage-gated sodium channels. These agents specifically block voltage-dependent sodium channels while they're in their inactivated state. This shuts down the influx of sodium ions, totally preventing membrane depolarization and stopping the action potential dead in its tracks. But that leaves us with a critical, high-stakes question to ponder. If these sodium channels are completely blocked locally, what happens when these agents accidentally slip into systemic circulation? Keep that systemic toxicity puzzle in mind, and we'll unpack it in our next explainer.